Okay, thank you.
Thank you for your kind introductions. Good afternoon, everyone. My name is Juno Lee, working in Samsung Changwon Hospitals. It's a great honor to have the opportunity to speak at this symposium. I would like to tell you about updated analysis of outcomes and evidence transfer thyroidectomy. The table of contents is as follows. First, let's briefly review the history of transfer thyroidectomy. Since first descriptions by Cockers in the late 1880s, the transcervical incision has contributed the primary surgical approach to thyroid and parathyroid gland. This traditional thyroidectomy facilitated a safe dissection and is associated with a low morbidity. Recently, quality of life after surgery is considered as important and encompassed more than just the process of treatment. As a reason, many different endoscopic or low-body operation methods to unmark or minimize the neck scars were developed, such as transaxillary approach, bilateral axial breast approach. And now, transoral thyroidectomy has spotlighted worldwide. There are many kinds of remote thyroidectomy approaches. BABA and TAA were performed widely. Transaxillary and retroauricular approaches have a major drawback. Operating on the contralateral side is challenging because the incision is only made one side. On the other hand, BABA have some advantage that total thyroidectomy is easily performed because it provides access from both sides using bilateral areolar incisions. However, it have a major disadvantage. That is, assessing in the deep neck areas for lymph node dissection is challenging, especially in the endoscopic method. But all of these approaches need more flap dissections. They are not truly minimally invasive and scary surgery. Finally, transoral approach was adapted. This approach has some advantage that both thyroidectomy and sentinel lymph node dissection should be easily performed under good surgical view, minimize the area of surgical dissections, that means true minimal invasive and scary surgery. In 2008, the first attempt for transoral thyroidectomy was reported, and this study noted that despite the complexity of anatomical reasons, the transoral procedure is easy to perform. Since then, there have been many attempts to perform transoral thyroidectomy using sublingual or vestibular incisions, and this study mentions some limitation of transoral thyroidectomy, such as infection, poor surgical view, tracheal perforations. In 2016, a study was reported. Transoral thyroidectomy was performed in 60 patients using three vestibular approach. It reported that operation times were acceptable. Moreover, the rate of adverse events were also acceptable, including recurrent laryngeal palsy, hypoparathyroidism, and infection. When the transoral approach was modified to vestibular approach, the incidence of complication was greatly reduced. In recent years, many researches have been published on the outcomes of transoral approach. From now on, I will talk about surgical safety and feasibility in transoral approach. In 2018, 2 years after the first report that 60 patients using vestibular approach, they report the result of a total 425 transoral thyroidectomy cases. Among 425 patients, 422 successfully were treated with the transoral endoscopic thyroidectomy. Only 3 patients were converted to conventional operations because of bleedings. It reported the operation times were acceptable, and the rate of adverse events were also acceptable, including blood loss, postoperative pain, recurrent laryngeal lobe palsy, hypoparathyroidism. Mental of injury, specific complication of transoral approach was reported in 3 patients. Compared to open thyroidectomy after propensity score matchings, there was no significant difference in operation time, blood loss, pain score. Moreover, there was no significant difference in complications such as recurrent laryngeal lobe palsy, hypoparathyroidism. North American groups also reported outcomes of transoral thyroidectomies compared to open thyroidectomies. In transoral endoscopic thyroidectomy groups, They had a difference for younger, female gender, small thyroid size, and large tumor size. Compared to open thyroidectomies, there was no significant difference in major complications such as permanent recurrent laryngeal pulse, hyperparathyroidism. However, there were differences in the operation time in transoral endoscopic thyroidectomy, both lobectomy and total thyroidectomy. Operation approach, transoral endoscopic or open thyroidectomy, does not alter the order of cumulative complications in a significant manner. Only increasing operation time independently increases the order of cumulative complications when controlled for the other variables. From now on, I'll talk about oncological safety in transoral approach. Oncological safety means surgical completeness, which is number of retrieved lymph nodes, thyroglobulin levels, radioiodine scan. This study shows safety of central lymph node dissection for transoral endoscopic thyroidectomy in papillary thyroid cancers. Every transoral endoscopic thyroidectomy was reviewed compared to the open thyroidectomy groups. There were no significant difference in number of dissected lymph node and metastatic lymph node. In these studies, the time consuming to perform central lymph node dissection was also compared, and there was no difference between two groups. And the other study also reported that no difference in central lymph node dissections compared to open thyroidectomy, both lobectomy and total thyroidectomy. In this study also reported postoperative thyroglobulin levels and stimulated thyroglobulin levels before RAI in total thyroidectomy cases. There was no significant difference in transoral endoscopic thyroidectomy groups compared to open thyroidectomy groups. This study analyzed 200 patients with papillary thyroid cancers who underwent transoral robotic thyroidectomy at Korea University in Korea. Total thyroidectomy was performed in 13 cases, and central lymph node dissection was performed in total 198 cases. This study included 40 cases of thyroid cancers rather than 1 cm in size as well as PTMC. Among 13 total thyroidectomy patients, only 7 patients were performed radioiodine ablations, and in total 7 patients, 6 patients achieved stimulation TG levels under 1.0 at first ablation time. Recently, several meta-analyses have been reported. From now on, I would like to show this meta-analysis. In this study, 6 articles are included in meta-analysis compared transoral approach to open thyroidectomy. Now, you see this forest plot comparing transoral endoscopic versus conventional open thyroidectomy. As you see overall effect estimate, the conventional open thyroidectomy was more effective in the operation time and amount of drains. There was no difference between transoral endoscopic and open thyroidectomy in number of retrieved lymph node and metastatic lymph node. And also, there was no difference in transient recurrent laryngeal palsy and hypocalcemia between two methods. From now on, I will talk about cosmesis, voice and swallowing outcomes, quality of life in transoral thyroidectomy. Despite the aforementioned advantage of transoral approach, the primary benefit of transoral approach is cosmetics. At this point, this study is to compare objective cosmetic outcomes between open thyroidectomy and transoral endoscopic thyroidectomy from both the surgeon's and the patient perspective. In total 81 patients, transoral thyroidectomy was performed 32 patients, and open thyroidectomy was performed 49 patients. Visual analog scale measuring color, contour, and irregularities are significantly deeper in both patient and surgeon's assessment. This graph shows comparison of patient and surgeon's rated total visual analog scale scores for thyroidectomy. Transcervical approach is left side, transoral endoscopic thyroidectomy using vestibular approach is right side. In the case of open thyroidectomies, there is a difference in VAS score rating between patient and clinicians. However, in the case of transoral thyroidectomy, both the patient and the clinician shows a low VAS score rating. And this study analyzed 160 patients who underwent transoral, transvaginal, or post-auricular lobar thyroidectomy, and the conventional transcervical thyroidectomy. 40 patients in each group. The post-operative cosmetic outcomes, including cosmetic satisfactions and scar consciousness scores, were evaluated at 3 months and 1 year post-operatively. The cosmetic satisfactions, scar consciousness scores, and the cosmetic index were significantly higher in the lobar group than in the conventional groups. And these scores was higher in the transoral and transaxial group than in the post-auricular group, but the difference was not statistically significant. The cosmetic satisfaction scores and the cosmetic index were significantly higher in the lobar groups than in the conventional groups at 1 year post-operatively. The scar consciousness scores were significantly higher in the transoral and the transaxial groups than in the conventional group. However, the scar consciousness scores in the post-auricular and the conventional groups were not significantly different. In addition, the scar consciousness scores about scar visibility, question 3, and the height of the neck, question 4, in the transoral group was significantly higher than these in the post-auricular group. This figure shows comparison of cosmetic satisfactions and scar consciousness scores and cosmetic index at 3 months and 1 year post-operatively. Transoral lobar thyroidectomy group shows that high cosmetic satisfaction and scar consciousness scores and cosmetic index, but there is no significant difference from other lobar surgeries. This study shows the functional voice outcome of patients undergoing TOEBA, transoral endoscopic thyroidectomy, were compared with those of patients undergoing conventional thyroidectomy. This is the first study to assess functional voice outcome, including pitch, after TOEBA compared with conventional open surgery. A total 82 patients were included in the study. 44 underwent thyroid surgery using TOEBA and 38 underwent open thyroidectomy. There were no significant postoperative change in voice workup in each group. In acoustic analysis, the mean high pitch and range decrease in the transoral group, but statistically significant was not obtained. This study was to compare the short-term voice outcome of transoral lobar thyroidectomy and transcervical thyroidectomy. 42 transoral lobar thyroidectomy groups. The acoustic parameters and the voice handicap index 10 scores were compared between the two groups postoperatively and 1 week, 1 month, and 3 months postoperatively. The postoperatively voice handicap index scores was not significant difference between two groups at any time. The highest frequency and pitch ranges was higher and bolder in the transoral lobar thyroidectomy groups than in the transcervical groups until 3 months after surgery. They reported the surgical approach, transoral thyroidectomy versus transcervicals, and the ages were independent factors related to highest frequency and pitch range in multiple regression analysis. This study reported swallowing outcomes analysis were conducted using swallowing impairment index scores. Assessments were performed preoperatively and 3 and 6 months after surgery. Propensity score matching was performed to compare the outcomes of two groups. So total 31 transoral endoscopic thyroidectomy enrolled in these studies. The transoral endoscopic thyroidectomy groups had swallowing outcomes that were comparable with the open thyroidectomy groups. This study was to compare the health-related quality of life after transoral lobar thyroidectomy and after conventional thyroidectomy. This study had 114 patients who underwent transoral lobar thyroidectomy, 57 patients, or conventional transcervical thyroidectomy, 58 patients, for the treatment of papillary carcinomas. They used two questionnaires, the University of Washington Quality of Life Questionnaire for head and neck cancers and the Thyroid Cancer Specific Quality of Life Questionnaires. The survey was performed preoperatively and 3 months and 1 year after thyroidectomy. Mean score for neck appearance were higher after surgery in transoral lobar thyroidectomy groups than the conventional groups at both 3 months and 1 year. Anxiety was significantly improved after surgery in both groups. Total score for health-related quality of life after surgeries was similar in both groups. Health-related quality of life and the overall quality of life over the previous 7 days was measured by quality of life questionnaires was significantly better at 1 year than in the preoperative period in both groups. Before the surgery, patients in both groups regard anxiety and mood as the most important aspect of health-related quality of life. After surgery, patients in the transfer ovary thyroidectomy groups identified anxiety, mood, and speech as the most significant issues, while patients in the conventional group selected anxiety, mood, and neck appearance. Scores for psychological well-being were higher in the transfer ovary thyroidectomy groups than the conventional groups at 1 year post-operatively. The psychological well-being score in comparison with the post-operative values increased at 1 year in the conventional groups, while the social well-being scores increased at 1 year in the transfer ovary thyroidectomy groups. Quality of life related to neck appearance is higher after transoral ovary thyroidectomy than after transurgical thyroidectomy. However, total scores for health-related quality of life did not differ in the two groups after surgery. In conclusion, recent years, many research papers have been published on the outcomes of the transoral approach. According to the results, the operating times between remote access approaches were not significantly different. Moreover, the rate of adverse events were also acceptable, including intraoperative bleeding, hospital stay, recurrent laryngeal palsy, hypoparathyroidism. As a specific complications, mental lobe injury was reported in under 4% of the patient, and when the transfer approach was modified to the vestibular approach, the incidence of mental lobe injury was greatly reduced. However, there are still some areas where further research is needed. In conclusion, transforaminal thyroidectomy is comparison and promising procedures with excellent cosmetics because it is not only oncological safety but also achieve a good quality of life after surgery. Long-term follow-up data and prospective randomized studies are needed for surgical and oncological outcomes of transoral thyroidectomy in the future. Thank you.